QAS was done, which was negative. Split for leprobacillus is also. Incisional biopsy was done, and it was reported as a conjunctive. And with this, I agree with this diagnosis as well, because it mimics. Patient got some treatment, but there is no improvement. Repeat biopsy was done. This is what I received. This is everything what I received. You see, so some epidermis, you can see some band-like lymphocytic assay, lymphocytic infiltrate. This is closer view. I can see band-like, some collagen also I see here, collagen with band-like lymphocytic infiltrate. And lymphocytes are going to the epidermis that I don't like. They are going to the epidermis. These are the cells. They are forming a nest. We call them as Darrier nest. Some call them Patrier micropsis also, which is a incorrect term. Darrier nest is the correct term. Okay, correct term. You see, they are atypical lymphocytes. Some have cleavage, hyperchromatic. They form the intraepidermal nest, known as Darrier nest. Yeah, you see, all of these atypical lymphocytes, they have halo. Halo is very important. If no halo, no epidermal tropism. Okay, halo is important. Halo surrounds the atypical lymphocytes. Atypical. This is dermis, full of these blue cells, atypical lymphocytes. With this, you see, these are the clinical diagnosis. Psoriasis, I do not think of that. I rule out all of them except MF. With this nest, epidermotropism, hallowed lymphocytes, I made a diagnosis of cutaneous epidermotropic lymphoid infection, favors mycosis fungoides. Because I do not diagnose the cutaneous lymphoma without ISC and without clinical picture. If I don't see the clinical picture, I don't diagnose lymphoma. And I gave some DD also. It may be MF and some other possibility. Lymphomatous papulosis type B and D, which show epidermotropism, and primary cutaneous aggressive epidermotropic CD8 positive cytotoxic T cell lymphoma. And I have sent the block to the Professor Kemp for ISC. He did it for me. And CD3 is positive in most of the cell, CD2 positive, CD4 positive, and CD8 negative. Then the diagnosis is done. Probably a small number of CD30 positive, beta F1. With these clinical pictures, microscopic picture, ISC, diagnosis is done. MF, plaque stress. Band-like lymphocytic infiltrate, you see only in plaque, not in plaque, only in plaque. Collagen is there, it is only in the plaque type of MF. So this is the mycosis fungoides, so it stands in the WHO classification. Patient got some better picture for 4 months and little bit of improvement I can see. Some more photographs which was after 6 months he developed a classic Hodgkin lymphoma of the inguinal lymph node. After 6 months, and he was referred to the medical oncologist, and I didn't have a follow-up. I'm not going to on this. This is more theoretical part. I'm directly going to case 2. And only one information I want to give. This MF occurs in the sun-protected area. Remember, sun-protected, not sun-exposed area. Sun-protected area. This one. This mycosis fungoides is also a misnomer, not a correct one. Some photographs of the patch stage. This is plaque stage. This is tumor stage. Some photographs from the book. I took it from the books, not mine. And this is patch stage. We see some hallowed lymphocytes in the epidermis. Maybe difficult in patch stage, but in plaque stage, diagnosis is not difficult. Plaque stage, tumor stage where epidermis may be lost, and some markers CD2, 3, 4 positive, 8 negative usually, but cytotoxic variant may be CD8 positive and 4 negative. Okay, and in molecular usually you see a monoclonality. It's a good prognosis. That's all about the case 1. I'm proceeding to case 2. If you have any queries, you can ask me right now. Because if you go to the case 2, we may forget together case 1. That's why. If there are no questions, then I'll move to the gusto. Okay. This is 55-year-old female. You see, lesion in the face and arms, forearms, some hairless. I can generalize each lesion. Later on, generalize. Started from face with mild exfoliation and lichenification. The description given to me by the dermatologist. And initially in the face, later on it involved other sides, hairless in some areas. These are some photographs from the trunks. So, dermatology residents, you can make a diagnosis now. I have shown you a clinical picture. So, two biopsies were taken. Two biopsies with a clinical diagnosis of dermatitis, ACD, psoriasis, and MF. Three differential diagnoses. And one biopsy was reported as a spongitic dermatitis. Again, it is a correct because it means. This is what I received. Second biopsies. This is what I received. See, very subtle lesion looks like in this part. I see some collagen between two hair follicles. Two hair follicles. Closer view, I see some spongiosis, some maybe. That's why the spongitic dermatitis, diagnosis of spongitic dermatitis was made because of these edema, this spongiosis is the reason why. But I see some lymphocyte, they have broken this muscle also, erectopile muscles. Spongiosis in closer view. And I saw, are there any typical lymphocyte? I should neglect it. I should ignore it. I'm not happy only with these two. I can't make a diagnosis with these two. I've neglected this. And I did a Elsen blue stain. You see, beautifully positive. You see. Now it is not a spongiosis now. It is a mucin. This helped me a lot. This helped me a lot. Because it is a mucin. No more spongiosis. Mucin. Now, these are the differential diagnoses given. Okay. These are the differential diagnoses. I have dispatched this as folliculotropic, minimal epidermotropic. You cannot write this. Typical lymphoid infiltrate with follicular. That is the follicular mucin is important feature. Strongly suspicious, I wrote. I can't make a definite diagnosis without IC. Strongly suspicious for folliculotropic MF. Strongly suspicious. And I searched the book also. I taken Cerrone. Cerrone says mucin deposition may be present or absent in pilotropic or folliculotropic microspongioids, and in his experience, is almost invariably found in the head and neck area. Almost invariably. If you ask my experience, I have reported two cases of folliculotropic MF. In both of them, I saw mucin. And if I see a mucin, I suspect folliculotropic MF. Okay, for me, it is synonymous. MF and mucinosis, almost synonymous. But there are so many other causes you see in the follicular mucinosis in other diseases as well. You see, I have copied only few. There are so many others. Okay, but for me, it is synonymous. This is, then I have sent the blood. You see, these are the red one. All are the lymphocytes which are CD3 positive. They have invaded the follicle. Everywhere you see, into the follicle, surrounding the follicle, some desmoplasia also there. Everywhere you see a CD3 positive lymphocytes. This is CD4. You see, most of them are even CD4 positive. This is CD8, which is negative. CD8 is negative. You see, CD3, small number of cells are CD30 positive. So now with this diagnosis made, CD3 positive, CD4 positive, CD8 negative, diagnosis done. You see, this is folliculotropic MF. This Professor Kemp did me some molecular studies also, but I am not very familiar with these tests because I don't do them. And I understand only whether it is monoclonal or not. Okay, as per this report, there is monoclonality. There is monoclonality that favors the neoplasm. Okay, and patient visited hemato-oncologist. Gets admitted, discharged. Bone marrow was done, which was free of tumor, and patient is getting some irradiation in one of the hospital in the country, and she is getting better. I don't have where this stands in WHO class. This is one more message here I want to give you. Unexposed area, just opposite of the conventional MF. Follicular tropic, unexposed, head and neck area, remember. You have to head and neck in the beginning. It may be generalized like in our case. So some photographs from the book or nets, different types. This is the pictures from the book I took. This is follicular tropic MF. Okay. This is similarly looks like a spongiosity in HNE, but it is mucinous, not a spongiosity. This is another picture showing follicular tropic lymphocytes. This is follicular tropic lymphocytes and mucin, both the things. So immunophenotype similar to MF. Okay, there is monoclonality and prognosis. Now the case 3. Any questions? This young boy, 11-year-old boy. The boy had some lesion. As a papule by the dermatologist. Papule, they say. And there is some necrotic papule. In the center, there is some necrosis as per dermatologist. Okay? And since last 5 weeks, they are multiple and progressing. Initially started from this one. You can see some necrosis in the center. Here in this picture. These are the differential diagnosis provided to me by the dermatologist. Okay. So deep mycosis, probably maybe, I'm not sure. Mycobacterial infection, okay, tuberculosis, leishmaniasis, and some neoplasm also. Neoplastic as well as non-neoplastic, both, you see. Both the differential diagnosis. And this is what I received, punch biopsy. This is everything what I received. See, subcutaneous looks okay for me at this magnification. I don't see much. And the dermis is very busy with these blue cells. Okay, this is very abnormal dermis. Very abnormal dermis. Full dermis is very abnormal. This is some elongation of rete ridges also you see. This is closer view. Closer view. Some you see epidermis here, some collagen I see in between. I'll have some this is more closer view. I see some sponges here. Some eosinophils or some neutrophils going up. Here also some eosinophils, neutrophils. Some cells they look like large lymphoid cells I say in this stage. Large lymphoid cells. This is closer view, and there are lots of eosinophils everywhere. Collagen here, lots of eosinophils. Okay, lots of eosinophils. And in between there are some non-eosinophils are also. Some look like a histiocyte maybe. Some show a little bit of grooving also. Here you see some multinucleate cell also. Some binucleated cell, some group. You see beautiful group here. You can see groups, nuclear groups, and lots of eosinophils. Nuclear groups, multinucleated, binucleated cells, and lots of eosinophils. Mitosis, yeah, exactly. Mitosis is also there. This one. Previous one, okay. This one, yes. This one you mean? This one. This one. Atypical mitosis. Atypical mitosis, yeah. Atypical mitosis. Lots of eosinophils. These eosinophils are torturing me repeatedly. Persistent, no fungus, isolated. See? ZN negative, gemcitabine negative for this one. See, these are the differential diagrams. I don't think of deep mycosis right now, with after seeing HNE slides. Probably there are no granulomas. Mycobacterial is less likely. Leishmaniasis is also less likely. Lots of neutrophil, eosinophil. We don't see in the leishmaniasis. It is unusual for leishmaniasis. And I am left with only 2 neoplastic lesions. You see, 2. And I have reported this as a cutaneous or typical lymphohistiocytic infiltrate with frequent eosinophils. This is my diagnosis. Probably dermatologists do not like this. Do not like this. They want a very firm diagnosis so that they can manage the patient. But unfortunately, they dislike this diagnosis as well as they dislike me as well. You see, and I made a two differential diagnosis, LCH and cutaneous lymphoma. Maybe, but I favor LCH. My number one diagnosis is LCH because there are eosinophils, there are cells with groups. Okay, plenty of eosinophils, there are cells with group, multinuclear cell as well. That's why my diagnosis is LCH. And I have requested Professor Kemp to do CD1A and S100. CD1A is some Langerhans cells you can see in the epidermis, but thermal infiltrate is negative. S100 is also negative. Now you see, I'm lost now. I'm lost. And along with me, dermatologists are also lost. Because they are not getting a diagnosis. You see, they are worrying about the patient. How should they manage the patient? You see, and I am left with only one diagnosis: lymphoma, because LCH is ruled out. LCH is less likely. No. There is no. There are some eosinophils and neutrophils going on. But there is no typical hallowed lymphocyte. Yeah, that also rules out. That's why I requested to do some markers of lymphoma. CD3, you see, most of the cells are beautifully positive. CD7 is also a positive. CD7 is also a positive, which is usually negative in the MF. CD4 positive, some of the cells, not all. CD8 negative. CD20 also negative. CD20 negative. CD30, 50 to 60% cells are CD30 positive. Now I'm very close to the diagnosis. Very close to the diagnosis. ALK negative. This is, I say this is CD30 positive T cell lymphoproliferatory disorder. WHO classifies only two. CD30 means only two: lymphomatous papulosis and primary cutaneous anaplastic large cell lymphoma. Only two by WHO. WHO classification is pretty incomplete. Many diseases are missing in that. And CD30 positive lymphomatous papulosis, I have taken it from here, and primary cutaneous anaplastic large cell lymphoma I have taken from here, and some cases of transferred MF also CD30 positive also. And cutaneous involvement of an anaplastic large cell lymphoma, ALK positive. If patient has a nodal disease, okay, primary cutaneous disease, ALK positive anaplastic large cell does not exist. It should be a secondary if it is primary disease. And patient doesn't have a lymphadenopathy. This is ruled out. Less likely. Only 3. So MF, you see, there is a patch, plaque, and tumor. There is some progression. You see, progression. And this patient presented with a necrotic papule. This clinical morphology is incompatible with MF. Incompatible, not compatible. Clinical feature is incompatible with MF. CD7 positivity unusual for MF. And strong CD30 expression is unlikely in MF. 20-30% cells may be positive, but usually more than 50% positivity is unusual in MF. So MF is ruled out. There is no more MF. Primary cutaneous anaplastic large cell lymphoma. Clinical finding is incompatible. They present as a nodule, multiple skin nodules. Here are necrotic papule. Morphology. Clinical morphology is incompatible with primary cutaneous anaplastic large cell lymphoma. And this CD30 positivity should be 100%. Book says more than 75. Practically we see 100%. So this is also unlikely. I am left only one. So with these clinical pictures, HNE pictures, ISC, diagnosis of lymphomatous papulosis type A was made. Type A. So this is where this disease stands in WHO classification. This see, lymphomatoid means lymphoma-like. Lymphomatous papulosis can resemble any types of the cutaneous lymphoma, any types. Morphologically can resemble, HNE can resemble any types of the cutaneous lymphoma, any types. And it presents with the papule. That's why the term lymphomatous papulosis. Okay. There are so many types. C, D, E, F, G, H. So many types. Okay. Differential diagnostic type is arthropod, A for arthropod. Okay, LCH as well in our case. Likewise, B, C, D, E, they resemble with these cutaneous lymphoma. Okay, H stands for Hodgkin lymphoma, F stands for follicular-trophic MF. Likewise, K for keratoacanthoma, like so many types. But Cerrone says so-called types of lymphomatic papulosis do not have any diagnostic or prognostic implication. Do not be included in the clinical or histopathology. As per Cerrone, type is not important. The prerequisite for the diagnosis is spontaneous resolution of the lesions, which is observed within a few weeks or rarely months. If you cannot make a diagnosis, wait till it disappears. It should disappear. It should disappear. Spontaneous remission should occur in 100% cases. They do not need any treatment. Okay, if they do not disappear, it is not lymphomatic papulosis. Okay, there are some pictures taken from the books: type A, type B, type C, type D, type E. Okay, type F, follicular-trophic. This picture is important. This picture is. You see, I can see here epidermotropic lymphocytes. Epidermotropic. You see, epidermotropic lymphocytes. With this picture, it can be a MF or lymphomatic papulosis. But there is clinical difference. If you see a papule like this, it is a lymphomatic papulosis. If it is a patch or plaque like this, it is a MF. But microscopic is same. That's why the clinical finding is important. That's why I don't diagnose cutaneous lymphoma without seeing the clinical picture. This is the reason. Now the case book. Do you have any questions to me? We can discuss together. I'll try to answer if I can. Please.
So now my voice is loud. I can calculate my voice will go fast. So I just wanted to say that as with kind suggestion in any sample biopsy, skin biopsy, very important that clinical photographs should along with some clinical pictures. That is what I do when I send him. We are trying to even prepare a atlas pathology and clinical because of him. So it's a mandatory that I send photograph, and photographs should be. Don't be casual. That we have sent punch biopsy to a pathologist. Now we expect a better diagnosis. The role is that all means the important history, finding, and at least your differential diagnosis. Sometimes you send sample without any differential diagnosis, without any photographs most of the time, and he complains time, and he tells me, Dr. Jha, you send me photograph, other they don't send me photo. That's what he says. Always that pathologists, dermatopathologists are here, and clinicians especially do that for your own benefit, not for the benefit of pathologists. For your, that he was worried that now how the dermatologists are worried that how to treat the patient. But for that you have to help yourself first, that to get a better diagnosis. Always send good picture, the clinical picture, some findings, and your difference. Thank you. Just
I'm moving to next case. This is a 81-year-old male with multiple lesions. You see, nodular lesion, cutaneous lesion, almost all over the body. Probably you can make a diagnosis here. These are some more pictures of the patients. This is nothing too much here. These are the clinical diagnosis, provisional diagnosis given to me. Lymphoma number 1. I do agree. Looks like a lymphoma. Cutaneous mets, disseminated, yes. Tuberculosis, leprosis, switch syndrome. Some more differential diagnosis. Let's see. So incisional biopsy was done from the thigh, and this is what I received. Incisional. This is not a punch. Epidermis, you can see it here. Entire dermis was lobule seeds of these blue cells everywhere. It has gone to the subcutis as well. You see, subcutis as well. It has infiltrated the subcutis as well. This is closer view. No much epidermotropism here. See, this lobular infiltrate here also. Some closer view. Most of them look large. Most of the cells look large, and they have involved the subcutis, intradermis. Okay, this is more closer view. You see, this adipocytic. This is a subcutis where the lymphoid infiltrate has involved the sub. And I made a diagnosis of lymphoma. That's all. Large cell in nature. Here I have no doubt reporting it as a lymphoma. But still, I did a ISC. I have sent the Professor Kemp. CD2 was positive in 100% cases. Cells, 100% cells, I mean. CD3 is negative. It's a good T cell marker, but it is negative. CD4 nearly 100%. CD30 100%. ALK negative, EMA negative. KI very high. So with this, again CD30 positive, 100% cell positive. Again, same differential diagnosis is previous one. And here we are very clear. It is not MF, clinical does not match, but tumor stage is possible. But 100% CD30 expression is unusual. Unusual. With this ISC, with this clinical picture, microscopic picture, diagnosis, primary cutaneous anaplastic large cell lymphoma. So this is where this disease stands in WHO classification. These are some pictures from the book. Okay, these are some clinical pictures, microscopic pictures. Yeah, there is no lymphadenopathy. Yeah, there is no lymphadenopathy. And this disease also, you see, in this disease also, you see spontaneous regression in up to 40% cases. This is a tumor with a indolent clinical behavior. Can spontaneously regress, but not 100%, like lymphodermatopathology. Case 5. Any queries regarding case 4? Okay, case 5. See, yesterday we had a Janai Purnima. That's why this is here now. Yeah, this is, you see, Janai we have changed yesterday. Okay, so this is 33-year-old male presented with a skin nodule. Skin nodule posteriorly. You see, skin nodule. And see, here I can see some lymph node. This is lymph node here, enlarged lymph node. Here, this is a cutaneous lesion. Here, lymph node. The scar of the previous biopsy. Scar of the previous. Okay, this patient has an enlarged lymph node since 1 month. Skin lesion since 2 weeks. That means lymph node appeared before the skin lesion. This is some more pictures. Okay, and the biopsy was done outside somewhere. This one is a lymph node. This one is a lymph node biopsy. I have shown you a scar. This reported as a C micro description. C micro description. Conclusion is C micro description. Right? Dermatologists do not like. I also don't like this one. Huh? And skin biopsy was done. Skin is reported as a malignant hematolymphoid neoplasm. Malignant is a very vague term. One chapter, yes, one chapter, very vague term. You see, I have shown you a book also on hematolymphoid neoplasm. Okay. This patient then visited to us. Once biopsy was taken with a clinical diagnosis of this hematolymphoid malignancy. This is what I received, everything, punch biopsy. See, everything blue top to bottom. You see, epidermis, thin epidermis, you can see it here. Everything top to bottom is blue. Subcutis involved. Everything blue. Everything lymphoid. Whole top to bottom. This is what I received. Everything what I received is this one, punch biopsy. And this is microscopic closer view. You see, most of these cells are large lymphoid cells. I say large neoplastic lymphoid cells. This is closer view. You see, now you can see the nucleus, nuclear detail, some prominent nuclear irregularity, some mitotic figures also. You see, I have made a diagnosis of NHL, no doubt. In diagnosis, there is no doubt. But I can classify it. I have to classify it. Then I sent the for ISC. CD4 beautifully positive. most of the cells. CD3 is negative, some interspose lymphocytes positive, tumor cells are negative. CD8 is also negative. CD30 almost 100%. Again, I am coming to CD30 again, almost 100%. ALK is also positive. Now this has changed my diagnosis. ALK positive now. You see, we don't see ALK positive primary tumor in the skin. We don't see. This cannot be a primary right now. TM is also positive. You see, beautiful. It's very beautiful. I see. They have done it well. And KI is almost 50%. So with this finding, again the same differential diagnosis. Now I have ruled out these three because of ALK. So with these pictures, with lymph node enlargement, with microscopic ISC, diagnosis of ALK positive anaplastic large cell lymphoma. ALK positive, which should be a metastatic, not primary. But in this case, we saw the lymph node also in patient's picture. That's why we are comfortable to diagnose this. So this is where this stands, secondary cutaneous T cell, secondary, not a primary. So this is theoretical aspect. I am not going to this. Okay. Case 6. In this case, I apologize for not being able to provide a microscope photographs because I have not seen this biopsy. I have got only reports. That's why I don't have a microscope. But this is very rare. That's why I want to show you. This is very rare. So patient has, I have photographs. Better, some visited multiple hospitals. Multiple tests were done. A patient got MDT with prednisolone. It's treated as leprosy, maybe. I mean, leprosy. Yeah, leprosy. He got a treatment for leprosy, and these are the pictures when he came to us. You see, necrotic plaque. I say here. You can better describe these lesions everywhere, all over the bodies. Some say EM-like, targetoid. Variety of description was given in this. You see, all over the body almost. And these are the differential diagnosis. Again, a lymphoma. Again, a lymphoma. We are discussing a lymphoma today. Some other granulomatous. Seasonal skin biopsy was done and reported as a spongiotic, non-specific, sorry, not spongiotic. Now, non-specific dermatitis. And this is the report I received from Professor Kemp. And according to him, he described some diarrheaness little bit, some parakeratosis, dermotropic, and some CD7 positive, CD8 positive, CD4 negative in this case. PIA1 positive cytotoxic, that means beta F1 positive. This is clinical pictures and the HE finding. This is, and with this diagnosis of primary cutaneous aggressive epidermolysis CD8 positive cytotoxic T cell lymphoma. This is the only one case we have seen. It is pretty rare globally, but this is the only first case probably. This case was seen by Dr. Mahesa, and where this disease stands, okay, in WHO classification. And patient before biopsy report, he got some treatment, but you see there is no much improvement. And after biopsy report, patient was reported to the medical oncologist, and patient passed away after 1 month of chemotherapy, and he survived 9 months with disease. And average survival 12 months in the book. WHO says average survival is only 12 months, and our patient survived for 9 months with disease. Okay, very aggressive disease. So this is some theoretical part. You see multiple necrotic plaques. Okay, necrotic papule, necrotic plaques, patch, plaque, nodule. These all have a meaning. You see, these are a morphological description based on clinical grounds, but they all have meaning. That's why I need a clinical photographs. These are some pictures from the book I have taken. Microscope differential diagnosis, cytotoxic MF. Okay, but you see MF, you see some progression from patch to plaque, which is not seen in this case. You see, involve the visceral organs also, this disease, but MF it is not, usually not. So they can be distinct clinical presentations. And it has aggressive course, median survival only 12 months, our patient survived 9 months. That's all. This is, I don't have a microscope photograph in this case. Do you have any questions to me? This is next case A, okay. This is patient 43 year. Next case 43 year. HIV, retropositive. Notice you can see photograph was sent by the patients. That's why he hit near the dustbin. Okay, maybe yeah. Yes. And ulcer is covered by a Dutch piece here, but when you remove it, looks like this. Down, yeah, it's coming down. That's why there is a dustbin. Yeah, that's why. So biopsy was taken from this nodule, not from the ulcer. That's why I'm not aware of nature of this ulcer. Few nodules over the bilateral limbs, ulcerative lesion, right leg since 2 months. New nodular lesion develop in the forward lateral, initially only in the leg. There is no peripheral lymphadenopathy, but CT and abdomen were not available. I don't know about the visceral lymphadenopathy, but there are no peripheral lymph. This is the lesion the patient developed later on. Later, initially only in the legs. Incisional biopsy was done. This is what I received. You see, there is a epidermis and see this infiltrate free zone here beneath the epidermis. Infiltrate is mainly in the dermis. You see, here also same thing. This area is free of infiltrate. You can see the infiltrate in the dermis. Again, almost same thing. This is little bit closer view. This this is a closer view. Most of the cells are large in size. There is some space around the cells. That is a clue for lymphoma. They are surrounding some eccrine ducts as well. They are destroying these muscles, erector pili muscles. I made a diagnosis of NHL with these pictures, with this microscopic NHL. And again, I have to do ISC. CD45 beautifully positive, most of the nearly 100% cells. This indicates that this is a lymphoma. This is a lymphoma. CD20 is nearly 100%. So this is the lymphoma which is CD20 positive. Previously, all were T cell lymphomas. This looks like a B cell till now. Till now, it looks like a B cell. CD3 negative, some interspecific lymphocytes only. MOM1 nearly 100% MOM1 positive. P138 may be positive, I am not very sure. BCL positives. BCL2 is positive. Ki67 almost nearly 100%, very highly proliferating tumor. ALK negative. ALK negative. This is the finding. So, if you see large cells, these are the differential diagnosis I have taken from the ceremony again. MAF, cutaneous anaplastic large cell lymphoma, lymphomatic papulosis, and all of them are B cell lymphomas. All of them. Only this one is a B cell. So I have gone with this because it is CD20 positive. So my differential diagnosis at this stage is primary cutaneous diffuse large cell B cell leg type. Initially only in the leg type. Okay, but my differential diagnosis another is NOS, DLBCL NOS, and this entirety is not recognized by WHO. In fact, I was expecting it would be included, probably included in 5th edition, but it was not. But there are so many reports, NOS, DL primary, DLBCL NOS, so many reports. And Cerrone also writes topics on this lymphoma, but WHO does not include it. And criteria for distinguishing this is BCL2. If BCL2 is positive, then we'll write a leg type. If BCL2 is negative, we'll write NOS. It depends on, and our case was MOM1 positive, that's why it is a non-GCB type, ABC type, non-GCB. And maybe DLBCL secondary also, nodal, and that has involved the skin, that is also possible. But in this case, there is no lymphadenopathy, and BCL2 is positive, so my diagnosis is number 1, leg type. And with these pictures, I have made a diagnosis of leg type DLBCL. So patient was referred to the Bharatpur Cancer Hospital, and I don't have a follow-up data. So this is, you see, in HIV patient, they have a high chance for the lymphomas. And primary fusion lymphoma, plasmablastic lymphoma, Burkitt lymphoma are more common. And in skin, B cell lymphomas is more common than T cell lymphoma in HIV positive. Authorized T cell, 80% of cutaneous lymphoma are T cell. If retropositive, then the ratio is reversed. So these are the little bit critical aspects, some pictures from the book. That's all about the last case. Do you have any queries? So this is the last case I have in this session. And the 71-year female, there is some lesion. This dermatologist say me there is some lesion. I doubt. MRI and CT scan says there is some lesion, and I personally doubt. I say there is nothing. Looks little bit erythematous, huh? Little. And what is the diagnosis? Dermatologist residence. So these are the two diagnoses given to me: eczema and tinea. I think you agree with this diagnosis. You agree? Two diagnoses were given. Okay, I also agree with this because I don't recognize the lesion. I should agree. This is everything what I received. You see, everything what I received. Once biopsy, subcutis. That this magnification looks okay. Very subtle lesion, some lymphocytes probably I see here, epidermis here. There is nothing much in low power. Let's see a more closer view. There are some lymphocytes I can see. That's all. Okay. I'm little bit unhappy because I don't like these lymphocytes. Why should they dissect the collagen? You see, they are infiltrating the collagen here. This pattern, I don't like it. They are infiltrating the collagen. And these lymphocytes are seen even in the soft cuties. You see, they are infiltrating the fat. This pattern is unusual for me. I don't like this pattern. This is another picture. They now look little bit larger than lymphocyte. Maybe I have doubt whether they are lymphocytes or not. But you see, they are dissecting the collagen. This pattern is very unusual. Very unusual. Dissecting collagen. For lymphocytes, dissecting the collagen is probably it's not a lymphocyte if it dissects it. I'm not happy. I did a pass system because dermatologist told me that it is a tinea. And I say this is neither eczema nor tinea. There is no spongiosis, no parakeratosis, no acanthosis. I do not agree with the diagnostic eczema and there is no fungus. And this picture I have taken from Ceroni again. These small lymphocytes, they are dissecting the collagen here. This is my picture. Okay, this is from the book. I compared my picture with this and I made a diagnosis of it from. Maybe a small round blue cell tumor, maybe interstitial MF, maybe. I'm not sure. Maybe some small lymphocytic lymphoma that has involved the skin. Maybe, possibly. Or maybe metastatic carcinoma, but I doubt it is unlikely to be a carcinoma because there is no cohesiveness. There is no cohesiveness, you see. Unlikely to be a carcinoma, but I have written one. 33 was done, all of them are negative. 320 also negative. Okay, some lymphomas may lack the CD3 expression. I then requested to do a cytokeratin. Beautifully positive. All these lymphocytes like cells are positive for cytokeratin. Yeah, mimicker. This is diagnosis metastatic lobular carcinoma. She had a history of ILC 6 years back. Looks like a lymphoma, but it is not. This is a mimicker. Okay, these are the some metastasis. You see, this is a breast scalp nodule. This is long nodule in the skin lip. This is scalp nodule, colonic adenocarcinoma. Okay, I am at the end. I'm going to finish. So I say these pictures always, you see, do not ignore the subtle clinical lesions. Please take a biopsy, you have doubt. Take home message. You see, so in this case, ALK positivity. Role of ancillary technique is vital for the diagnosis of acute lymphoma. I do not diagnose without it. See, this picture can be a MF, can be a lymphomatic papulosis. Clinical picture is must. Metastatic carcinoma can mimic a lymphoma microscopically, or sometimes even in ISC, but ISC or monoclonal assessment is required. Follicular mucinosis is a good clue. This one is a good clue for follicular tropicoma. Do not forget. This message you have to take to home. Okay, B cell is more common in HIV positive patients. This one. And some, क्या है माथि? यो माथि घटाउ दो. Hey, okay. Hey, okay. This is some clinical clues for dermatologist. I have prepared this slide only for dermatology. So, if you see phase plaque on sun-protected area, think of MF. Think of MF. If you see papular small or small nodular lesion like this, think of lymphomatous papulosis. If you see solitary plaque on head and neck, think of primary cutaneous CD4 positive small medium T cell lymphoproliferation. If you see alopecia in follicular base lesion, think of follicular trophic MF. If you see rapid onset, fast progression of multiple this type of lesion, you see necrotic plaque, then think of primary cutaneous CD8 positive aggressive. If you see rapid onset, fast progression of tumors on the leg, think of primary cutaneous diffuse large B-cell leg type. Thank you very much. Thank you for your attention.
Very much, Professor. Before the session started, and I you are the man today. Today we were like panicking. You are the man of today. My comment, telling me yesterday presentation was the standard of presentation. Everyone agrees that your presentation was far more excellent.
Thank you. Thank you very much. Thank you. Thank you.
Second comment I want to make is dermatologist hates you to that statement because I am in continuation with balancing vital flower of our garden. I always come with guides or dogs for second opinion. So humble that tells we have to, the patient don't have to. That is his humbleness, and that's why.
Thank you very much. Thank you.
Dermatopathologist. So now the floor is open for question.
Please, ma'am.
It was an excellent presentation, and what I liked about the presentation have just stressed that in every purpose by the clinical dermatopathology, clinical pathological pathologist also see that helps. And just one query to the dermatologist in the house today. How comfortable are you with the diagnosis of mycosis? It is we have discussions that this diagnosis should be avoided because as soon as the diagnosis is made by the pathologist, the tendency for the dermatologist is that he refers the patient or she refers the pathologist. Who is it for you all? I want to know your experience. Is it true that as soon as the diagnosis of that or the I'm loud enough.
Yeah. Dr. Smita.
So I think the best person who is supposed to answer this question is not here. So I personally know Dr. Sudeep Parajuli sees most of the lymphoma cases, as far as I know, like a maximum number of lymphoma cases in Nepal. And we had suspected a few, very few, like handful, maybe 2 or 3 patients with MF, and I was in discussion with him. And according to what I knew from him, it's not always that we send to oncology. It depends on the presentation, the stage of the disease, and many more such things. So I don't think labeling a patient as MF by a pathologist would make us, directly send them to oncology, but make us more vigilant in, monitoring them in terms of whether the lesions are clearing up or not, and for the systemic involvement.
Thank you.
Yeah, thank you for your question. That you mentioned that once we diagnose mycosis fungoides, means straightforward send to the oncologist. In usually I don't do. Yeah, I treat them depends upon their severity, and we work together. So I have treated some of the cases, and even I have diagnosed mycosis fungoides in 2016. Patient went to, once I gave the report, he wants to go another center. So let's him to go. 5 years he went to different center. He went to Delhi. He has some treatment. Then he came to Nepal also. He had twice beam therapy. And lastly, I am treating again 1 year that patient with mycosis fungoides. But he has no, we can say that metastasis, other problem, it is not there. So it is not always that once we see that all the cases, surely depends upon the patient affordability, their desire. We have to take consideration. If the patient is not able to afford, they have no access on that situation, we just can't leave that you are, I'm a dermatologist, I'm a not oncologist, so I will not treat. That is not justified.
What I meant to say is that most of the time the patient doesn't need treatment, onco treatment. He needs to be treated just like a chronic case of dermatitis. Most of the time, like patch stage and all, they don't need any oncology treatment. So that is one question, and another question is a comment. Another is a comment on your case of mycosis fungoides. That IHC markers are not diagnostic for mycosis fungoides. Mycosis fungoides diagnosis is made by clinico-pathological correlation. IHC always helps. For example, CD7, CD5, they are supposed to be lost. The T cell markers are lost in case of mycosis fungoides, and CD8 is supposed to be negative. But I had a case of the diagnosis, but they will not make the case, they will not be diagnostic for mycosis fungoides. Diagnostic for mycosis fungoides is always clinico-pathological correlation. That
Can
is
I
the
make
only
a comment?
comment.
Yeah. First, I must tell Professor Ramchand, it was amazing.
Thank you.
Yeah, amazing presentation, and you have raised the bar of presentation than yesterday. Because yesterday it was all MRI and CT scan. Today you have shown the microscope, right? So bit above. Now my second point is what we have been discussing. Dr. Shubra raised this because amongst the dermatologists, this is often being asked. The reason being, the moment mycosis fungoides is diagnosed by the pathologist, many of the dermatologists they feel shaky and they press the panic button because the patient might go for litigation if there is any mistake in the treatment or the approach, because their perception is mycosis fungoides means an oncologist area. No, it is not. We read mycosis fungoides, we have been reading it for last 25 30 years in our textbooks, standard textbooks, Brooks and Fitzpatrick. Patch stage, even up to early plaque stage. Only in the tumor stage you need to refer it, or multiple organ involvement, we need to refer it to the oncologist. Many of the mycosis fungoides, they disappear on its own, as Subra pointed out very rightly. So I think this point should be very clear to everyone, and it should also be clear why this point was raised, because this type of questions are being asked in our IADVL different meetings when there is a clinico-pathological colloquium. Both clinicians, dermatologists, and pathologists should be clear to everyone. Thank you.
Rouse against WHO also actually. Should remove the patch and plaque stage from the lymphoma thing so that no, patients are not referred to the oncologist
Oh.
when a case of diagnose a case of mycosis fungoides.
While listening your presentation, today I remember around 35 years back, my pathology teacher in MBBS class was so confidently pointing out like. So I'll discuss one thing today. Why Professor Ramchandra is associated with Daisha. If you do not know that, so there are only few pathologists who can read dermatology diagnosis. I can count. And there were many before him who was associated with Daisha, but none of them could cope up with. Then ultimately I got him, and I requested him because his dedication, his reading, and his dedication, especially towards his subject, was so honest that I requested him to be and fortunately we were fortunate that he joined, and when he joined then he was sent to the Zurich Medical University for 3 months dermatopathology special training, and then he became more confident, and so today he could point you all like this, that what you were saying is always right. He was very confident. If you have knowledge and confidence both, you'll be like him. Thank you.
Thank you.
Thank you, Professor Ramchandra. Now,
All right. Good evening.
But I can hear you. Please go ahead. No problem.
First of all, so probably you don't know me, sir. I am Dr. Needas Parazuli. I work at Beer Hospital, but we are connected to cases. Two of your cases, I saw it. I'm lucky enough to see it on the first time, unlucky enough not to make a proper diagnosis. The
Okay.
first, I'll go with the last case, so, where you don't have the clinical picture. The case came to me as a case of
Hey, don't have a microscopic pictures.
you know, like an aggressive type of.
That clinical picture I had, but
Yes,
microscopic picture I didn't have.
I'll go with the earlier presentation.
Hey,
of it.
okay.
The earlier presentation, I saw the form of erythema multiforme. I
Okay.
was very confused. I thought it was bug. I usually treat them with just acyclovir, but this case I did a biopsy, and my biopsy colleague called me after a few days saying that what you did send me for all lymphocyte everywhere, and then I popped up nothing there. Colleague from Groningen, and he was. So that's how it landed up with Dr. Mahesh Sir.
Mhm.
But it was more to do with erythema multiforme, like at the first instance. Second one, and then probably I'll give the comment to my colleagues, other colleagues, the comment you had with the pathology. That is from my issue. The lymph node,
Hey,
it gets
okay,
closed.
okay. Hey, okay, okay.
But I think it's like we need how we are going along, and then that case at the diagnosis, I called Subha. Have a look at it. Very happy with it. So following up that case, chop therapy for very time. After chop, there was only one lymph node that was left. We excited the lymph, but after that, started chop, but after that, long case. That's why I remember this. our thing. Lucky that we couldn't do much for this. Thank you so much. Sir, anyway, it was
Okay,
very
thank you.
impressive, sir.
Thank you.
That, I think
That whenever we suspect malignant cases like case of malignancy, we said that we should send incisional biopsy instead of pons biopsy. So is there any preference for doing that?
No, for me both are good. No, both are good.
For,
No,
for
both are
clinical-
good. Usually punch biopsies are little bit deeper. Subcutis you can see in punch biopsy. In incisional biopsy, usually I don't see subcutis. Punch biopsy is also equally good, less traumatic, equally good. If it is taken from the lesion. If it is little bit outside the lesion, then incisional covers more area, maybe better. If you take a tumor, for me both are equally good. No problem.
okay. Thank you very much, Professor Ramchandra. We are running out of time. That's why I'm hurrying. Dr. Mahesha is going cutaneous leishmaniasis, a
Um, Good evening, respected chairpersons, Chairman Dysart Professor Jha, and our guest Dr. Sandeep, and all we can say that colleagues, and I can see that we have very energetic, knowledgeable dermatologist and more pathologist with us in this hall. So I would like to say that I will be talking little bit regarding the cutaneous leishmaniasis. First of all, I would like to say that I have no any conflict of interest because I will be talking only on the behalf of, we can say that, clinical researchers, or we can say that for the scientific purpose. Maybe those patient I will be showing the photograph, or maybe you clinician you have met those patient, but I will not say that I will be humiliating anybody. Just it is because my presentation will be like a story. I am attached with the, we can say that in the hospital, not I am a working in the medical college. So my presentation, it is always, it is the voice of the patient. Yeah. So you don't feel bored. Just I will try to do something maybe useful for you. And all the presentation, some of the patient, we have very good correlation among the clinician. Any difficult cases, we talk with Professor Jha and other colleague in Dysart, and also we have. I can say that I am just Dr. Jha has mentioned. Now I feel very proud. I feel powerful because there are now I have three helping hand. One it is Professor Ramchandra. Second, we have I haven't met him, but he has helped a lot. Professor came from Zurich. And third, we have young my colleague, Dr. Subhas. So with this help, I have those patients which I can make the confirmatory diagnosis. Yeah. Cutaneous leishmaniasis is a vector-borne disease transmitted by female sandfly and caused by Leishmania protozoa. In the 2021 WHO, there are always every year the reporting of the CL cases, and among the 200 cases, 99 country has a report considered as endemic for leishmaniasis. Among them, 89 were endemic for cutaneous leishmaniasis, and 80 were for the endemic for BL, visceral leishmaniasis. 71 are for both BL and we can CL and BL. CL skin lesion most commonly occurs on the export part of the body, face, extremities, and it may living with residual scar once, and so that is may cause disability and stigma. Nepal is considered endemic for visceral leishmaniasis, so minimal data is available for cutaneous leishmaniasis. Recently, the cases of indigenous cases of leishmaniasis have been reported in Nepal at different centers. This is the map where we can see that in 2021, visceral leishmaniasis, we can see in the we have neighboring country, it is India, Brazil, yeah, they are reporting more than 5,000 cases per year. And we have already you have mentioned there are so many countries, but number of cases are less. Once we see the WHO report in regarding the CL, you can see in the Iran, Afghanistan, yeah, those area, also again in the Brazil. And we have neighboring country, we can see the India, Nepal, we have very few cases. So that is we can see that different pattern which we can see in the, again the, since 1998 to 2001, you can see the BL cases are coming down. But the CL cases is increasing. Yeah, vice versa is happening. Yeah. So I've gone through the government of Nepal EDCD report. There in 2076, there were 22 CL cases from different district has been reported. But there are so many case report, but it once we go through the government data, we can find only few only. Yeah. First, I will talk little bit about the immunological thing. Here it is. You know that leprosy it is a immunological. I say that it is a caused by Mycobacterium leprae, but everything is displayed according to immunological status of the host. Similar pattern you can see in the leishmaniasis. It is a spectral disease. Depends upon your, we can say that host hyperenergic, yeah, delayed hypersensitivity, and you have parasite will be very less. Another opposite pole, you have less cell-mediated immunity, so you have more parasite, but you can see the multiple. So more parasite is there, so there is formation of antibody. So diagnostic point of view, it is that CL cases because you can have, we can say that in the when it is the good cell-mediated immunity, you will develop the localized CL, but if you have poor cell-mediated, we can say delayed cell-mediated immunity, then you will develop the mucocutaneous and or maybe you can have disseminated cutaneous leishmaniasis. Again, in the visceral point of view, maybe asymptomatic infection, maybe subclinical syndrome, maybe clear-cut visceral leishmaniasis with fever, everything, and patient will be looking for the treatment. These are the pictures, certain pictures which we say that if it is a localized, you can see only few skin lesion, but here it is mucosal involvement is there. There is multiple skin lesion, and in our setup, we'll see it is a, because we have cutaneous leishmaniasis, it is very few, so it will mimic to the leprosy because most of the skin lesions are asymptomatic. Diagnostic, we have very few options, which I'll say that still because we can do the scraping, and we can see the LD body. Once we do the biopsy, we can in the biopsy if we can find the mastigocytes, LD body, then it is in Jim system, then we can confirm the diagnosis leishmaniasis. But we haven't molecular diagnostic tool. Still, we can say that limited resource countries we are lacking. So sometimes we are very difficult to diagnose the leprosy. CL. Yeah. So this is my own cases, which I have seen. CL cases. You can see it is all the hilly area. Yeah. Nepali, Karnali, yeah, Kalikot, Dolpa, Rolpa, yeah, Bajura. Also we have from Baitari, yeah. Also we have from it is Ramesap. Our location is located here. You can see patients are coming because they have asymptomatic skin lesion and they don't get the proper diagnosis and their skin lesions are not cured. So I will be discussing few of the clinical pictures of the patient. This is we can say that in 2006 I have diagnosed the first cases of CL. So 33 years male presented with asymptomatic skin lesion on left wrist and tip of nose since 3 months. Has a history of erythematous indurated plaque on dorsum. Yes, so it is the same sensation because he thinks it may be the leprosy. Yeah, because in our center most of the time asymptomatic skin lesion, that if it is not improve with usual maybe steroid, maybe antifungal or eczema treatment, then they will come to us because it is already chronic. So once we check for the leprosy, sensation was normal. He was a resident of Lalitpur, job holder, but he has history of visiting to the hilly area of Nepal and also Karachi. So this is the clinical picture. We can see in the nose erythematous indurated plaque. Because he mentioned that he has history of visiting to the hilly area. So my first diagnosis it was sarcoidosis. Then we can say that leprosy, lupus vulgaris, rosacea, and that time we have provision that we can send the biopsy to the India only. Yeah. So I take the biopsy and send to India, and with the finding of slit skin smear negative, K39 negative, and biopsy came, it is cutaneous leishmaniasis. So that was not in my differential diagnosis. So dermis shows multiple confluent granuloma composed of histiocyte, epithelial, and also in Giemsa stain they can see the LD body is seen. So final diagnosis, it is cutaneous leishmaniasis. It is, I can't see anything, but for your eyes, I think you will see more. So it is a, we can say, diffuse lymphohistiocytic infiltrate in HSN. In Giemsa stain, you can see some LD bodies, yeah, LD body. And with me, Professor Ramchandra is here, so he can explain you in anything it is needed. My final diagnosis was cutaneous leishmaniasis, and I haven't medicine to treat, so I sent the patient to the teaching hospital, and the patient was treated with intralesional sodium gluconate, and you can see the now the nose, yeah, is a actually there was goggles, but I've hide it, yeah, to show you now. Second case, it is 40 years male, presented with red skin lesion on nose, cheek, left elbow. Started as nodules on the bridge of nose, and history of 5 months. He presented with erythematous, you can say some swelling also there on the nose. From Surkhet, job holder, but from Surkhet it is not far, so he can sometimes go Delhi, sometimes go the Lucknow. Yeah, sorry, sorry, back. So he was from Surkhet, so he first visited to local place, and it was diagnosed as cyst, aspirated, antibiotic given, antifungal given, not getting better. Then he visited to another place, Nepalganj, and again antibiotic was given, not improved. Then he visited to, now he is coming from Surkhet to Nepalganj, now he arrived to Kathmandu. In the Kathmandu, he went one of the hospital, and they think it is maybe, so you can see the finding, it is ANA positive, MAN2 test negative, advice for biopsy for histopathology. On that setup, it was not available, so he was referred to another hospital for the biopsy with the differential diagnosis. We can see it on the nose, so it is rosacea, lupus pernio, DLE, granuloma faciale. Biopsy reports suggestive of lupus vulgaris. So it was advised to start anti-TB drug from the DOTS clinic. So it is 5th place he is going. Patient did not agree to take anti-tuberculosis treatment. So he visited to another dermatologist in Kathmandu to have second opinion. And another second dermatologist also see the report. He become agree that biopsy picture, it is matching with the lupus vulgaris. Then lastly patient agree to take the anti-TB treatment. He take the anti-TB treatment, but he was not getting better after 1 month. So he visited to the same dermatologist who has prescribed the anti-TB treatment. Then dermatologist thinks, oh, okay, maybe then it is leprosy, VT, Hansen's. So he think it's a type 1 reaction, and he added prednisolone because it will help, and continue the anti-TB drug. Still the patient does not get better. Then lastly, he visited to, again he went to the local place, Surkhet, and he visited to the leprosy clinic. Because one of the dermatologists already has said it may be leprosy. Then the patient was referred to our center, Anandban. And we did the biopsy. Several biopsy, nothing was conclusive. There was also, it was 2015, so there was, we can say that mega earthquake. So we are cut off. So lastly, he decided, why not to go India? So he went to Gujarat. There also, dermatologists think it is chronic cutaneous leishmaniasis, lupus perniosia. Biopsy was done. Still the report is awaited, but in between, what were the findings? That we can say that MUNT was negative, serum ADN negative, smear for leprosy it was not found. So all the test it is, we can say nothing in the Zimsa stain also, which we have done the scraping, was also negative. So I mentioned that pathologist who first time in 2006 said it is cutaneous leishmaniasis. Now the pathologist is not in position to say that it is a crusted lesion, because I find that clinically leishmaniasis lesions are very soft and fragile. Once you take the biopsy, it is हिलोमा यसो औँला हाले जस्तै जान्छ. So it is very soft and fragile. So it was not possible to give the diagnosis. So in between, we sent the biopsy to the Switzerland, and again you can see in the lower power, again in the high power you can see the diffuse lymphocytic infiltrate. Here you can see vague granuloma, and lastly you can see some healthy body. So final diagnosis is cutaneous leishmaniasis. By the time you can see the patient came when the final diagnosis on this skin lesion, it is already more swollen, more worse, and we are dermatologists. Now we are talking only the acceptance, face. If you haven't charming face, you can't do anything. How much it will be embarrassing for him, because he was a job holder. Also he has lesion in the arm. So we can see that till that time patient completed 6 months anti-TB drug. Also, sorry. Okay. And also prednisolone, but without improvement. So we can see that patient visited to 7 dermatologists. 3 biopsies were performed. It took 9 months to have final diagnosis, and patient was referred to TECU. We have in EDCD, we have miltefosine, and it was started after 2 months of treatment. So even with the treatment of that, any treatment given for the leprosy according to guidelines, treatment it is maybe we can say miltefosine it is 4 weeks only. Guidelines it is there. There will be surely skin lesion will be regression, but not the full recovery. So after 2 months, we can say that some improvement it is there, but it is not fully resolved. So after 6 months of treatment, in between patient is not getting any treatment. So it takes time to resolve. So a lot of assurance is needed to the patient that your diagnosis is correct, you have taken the proper treatment and it will resolve slowly. So after 1 year, you can see now nose, same nose it is there. I haven't done any cosmetic. I have treated with only miltefosine and asked the patient, you can apply some moisturizer or sunscreen, up to you. My third case, maybe you are maybe boring, but still I will say that I will try to minimize my talks, minimal. But again, it is third case. It is 31 years male presented to us with red skin lesion on nose and cheek. Yeah, and lesion started as a small nodule on the nose 7 months. On the cheek, it is 5 months. You can see in the lesion on the nose, on the cheek. He is a resident of Ramechhap and he has a history of travel of Nepalganj and Rolpa. I mentioned Rolpa is also one of the now endemic or CL. So he visited one of the medical college, dermatology department. VDRL was the non-reactive, MON2 test done. Differential diagnosis was lupus vulgaris and sporotrichosis. A biopsy for histo was done and also referred to medicine department for further evaluation because our diagnosis provisional first it is lupus vulgaris. So we like to be sure that patient has any internal involvement or not. In the medicine department, they work out and okay, we ask the patient. So he says, oh, on and off, I have fever, 3 months. Cough, chest pain, present. Okay, sputum for AB negative. Chest X-ray was done. Opacity in the left lower zone. Differential diagnosis, it is granulomatous lesion and advice for CECT chest by the physician. So suggestive biopsy report came. It is suggestive of lupus vulgaris. Advised to start anti-TB drug category 1 and refer to DOT clinic. Skin lesion was not improving, so again the second biopsy was done in the same medical college and now the scenario is changed. Previously it was lupus vulgaris, now it is suggestive of tuberculosis leprosy. And the patient was advised that you have to take the anti-leprosy drug. Then I received phone call that I have a patient who is taking TB drug also. He is taking